I want to start off by saying that a lot of work in Jawadhi has been possible thanks to the various FOVs and the FOV UK. And let me start by thanking you for your prayers, for your support for our work in Jawadhi. So again, I'll give a quick brief introduction in keeping in mind that I have 20 minutes, but this is where Jawadhi is. Uh, Vellore is here. This green area is Jawadhi, and it's a part of Tamil Nadu, in the northern part of Tamil Nadu, not very far from Chennai. And there are some of you on today's meeting who have visited this area. So I want to start off by just telling you about three stories of three women who died during their pregnancy and delivery. And all three have very unique situations, because generally when we talk about Jawadhi, we talk about poor geographic access to healthcare. And we found that it's always not just the access to healthcare which is causing women to die or for us to have maternal death. So very quickly, this is in a village called Periyatattankotai, and this is a young lady, 21 years old, called Tamila, who had a home delivery because she could not reach the hospital. Her house is in a place which doesn't have road access. So she delivered at home. She had a retained placenta, and she bled a lot. And by the time it was daybreak and they could actually take her to a place where there was cell phone coverage, she actually died. A place where there was no geographic access to healthcare, because there was no phone coverage for them to call for the ambulance, nor was there a road for the ambulance to reach. The second is the second person I want to talk about is this lady from a village called Vallikottai, which is just 2 kilometers away from the main PHC, the main primary health center in Jamnamattur. That is the biggest town in Jawadhi. This lady, unfortunately, was a migrant laborer. That is, she is a tribal lady from Jawadhi, but she had migrated for labor, therefore had not registered for antenatal care in Jawadhi. So when she went for antenatal, went in labor, she was referred to another PHC, which was 20 kilometers away, and from there referred to another PHC, which is 35 kilometers away. By the time she reached, she was quite sick, and she died after a cesarean section. Her baby is now 3 years old. And this lady who I want to talk about was actually registered with us in our mobile clinic. But when she went into labor, because we don't have a 24-hour service in Jawadhi, she went to the local PHC where she was also registered in Namyambet. And she had eclampsia, so they referred her to Odugatur. But Odugatur is a place which is quite far for her. She was not familiar with the place. She was afraid to go there, so she went home, died at home, and her child is right now being supported by the department. So all three, one patient where geographic access was a problem, the other one was very close to the PHC, but then because of migrant labor, she was not registered, and there were issues in the government about taking her. And this lady registered with us, but again, no services in the night. So this is the background with which we are sort of basing all our services, trying to decrease maternal mortality in Jawadhi. And of course, in between, COVID happened, so we had to sort of focus a little bit on the pandemic. But then still the main focus now is in establishing a center for MCH care in Jawadhi. So again, very briefly and quickly, for somebody who's not been to this area, Jawadhi itself, it's part of the Eastern Ghats. Size-wise, it's about 2,500 square kilometers. It's home to a tribal population of about 60,000 tribal people and another 20,000 non-tribal people. And the general health indices there are low, as well as the development indices. The terrain itself is a bit inaccessible because it's the Eastern Ghats, and it's made up of little sections of hills and not a continuous range. Therefore, access becomes difficult. And on the whole, this tribe has been isolated there, so there's a little bit of mistrust and suspicion about working with outside people like us. And so there's a lot of building of relationships which has to be done before we can actually work with the community. And in total, there are 294 villages and hamlets in Tiruvannamalai district and another 94 in Vellore district. Administratively, the government has divided it into these two regions. Other than CMC, there are actually 5 primary healthcare centers, but only 2 actually in the hills. The other 3 are serving the hills, but they are in the plains. Then there are sub-centers, but they don't work. There are some other NGOs which work here, the Red Cross and SRM from Chennai comes here and does some clinics and goes. There are many research excuse me, projects from other colleges like VIT and Narayani. The whole area has 1 veterinary clinic. And for this entire population of about 400 hamlets, there are only 5 higher secondary schools, and they are all situated in that same place, Jamna Matur, which is the sort of capital city of Jawadhi. So very quickly, some health indicators. We don't have very recent health data because our survey data is not complete. We've not been very successful in getting good data because of the migration of the people, and we are only now cleaning up our data to analyze. So if you look at this, you can see compared to Tamil Nadu in India, in 2007 when we did our first survey, 2012 when we did our second big survey, and now we have only small survey data. Jawadhi actually fares quite badly when you think of it as being part of Tamil Nadu, where the health system is supposed to be quite good. But the immunization rates and the other things I'm talking about below here are all current. So even now, completed immunization is less than 30%, and about 50% of the women are still delivering at home. Even though they are almost 90% of antenatal women register in a PHC, delivery actually happens at home because there's no transport to get them to hospital on time. And other indices also like education, employment, and all the other health development indicators are relatively low in this place. Like many other tribal regions, alcoholism is a problem, and in surveys which we did recently, we found that 54% of adult males in this region are hazardous drinkers. And I put it here because whatever programs we implement in this region, we have to keep in mind that we have to address substance abuse first. Otherwise, the women are not able to access our services if the men are not if the men are drunk. Some more data, a little more recent from 2015, the crude birth rate was 28.7, the death rate and the infant mortality rate, as you can see, is much worse off in Jawadhi compared to India. Some other data about child nutrition, which is now what we are focusing on, because we found in the pandemic that two things happened. One is education really slipped. Children who were supposed to be in the beginning of the pandemic, if a child was, for example, in grade 3, now 2 years later, because 2 years the schools have been closed, the child is supposed to be in grade 5, eligible to go to grade 5. But when we looked at their academic level using the ACER tool, we found that the child who was in grade 3 at the beginning of the pandemic has now slid down to grade 2 or grade 1. Children are not able to form alphabets. A child in grade 8 is still spelling out words and reading. So academics slipped. The other thing that slipped was child nutrition, because midday meal stopped. No schools, no midday meal. So children who were borderline became malnutrition, and children who are already malnourished slid down further. So this is some data. It is old. We are currently weighing children now in our night schools, and that data I'll be able to share with you maybe in a month's time. But already to start off with, these were the levels, with 60% wasting and 63% stunting, which is a reflection of acute and chronic malnutrition. And anemia, micronutrient deficiency. This is gross nutrition deficiency. In micronutrient deficiency, we found that among tribal children, anemia is quite high. 35% of adolescent girls in the region are adolescent children in the region are anemic, as compared to 17% of the non-tribal children. And if you look at the medical causes of mortality here, for maternal mortality, it's mostly things which we'll expect in a geographically difficult area like eclampsia, sepsis, PPH, and underlying anemia, which is compounding all this. And in children, it is mainly infectious disease still, because immunization is low. There are outbreaks of disease and perinatal deaths. In adults, most of the women MCH problems, tuberculosis is quite rampant here. We found that cancer deaths are common here because people are not getting to hospital on time. And the commonest cause of death among young adults is road traffic accidents, usually due to the influence of alcohol. And these are some of the social causes which I already spoke about for mortality. So my presentation is actually like focusing on this area. So this was our response to it. So to improve access to healthcare, which seems to be the biggest problem here. And the second thing is, like I said, because of the little bit of distrust between the people in the hills and the rest of the community, health-seeking behavior is not common with the allopathic system. they have their own indigenous system of health, which they go to regularly, but very often it's not, meaning it doesn't help. And the other big area we are looking at from the department is to address the social determinants of health. That is all our development programs which we are doing in Jawadhi, and substance abuse, which is underlying problem which we'll have to sort out if we have to improve health or development in this area in any way. So I think some of you, I'm sure, definitely Ruth has visited the center. This is our center in Jawadhi in a village called Veerapnur. This is my colleague Anu Alexander who's here. And we have a hospital here which we are running 6 days a week, but it's only in the daytime because we don't have a facility for staying. And as many of the admin in the FOB UK know, we are in the process of buying this land, a 4-acre piece of land from the Don Bosco Tribal Development Society. So that is in that again. It became delayed because of COVID and the pandemic closing all the government offices. But we are pursuing that again now. So these are the services which are offered in the center. There is a day clinic which runs every day, like I said, and the patients who come are usually general mobility patients, chronic diseases, patients who have chronic disease cards who come for refill of medicines, antenatal and postnatal care, immunization, obstetrics, and pediatrics. We also have fixed clinic schedules for which I'll show you in a minute, and specialty clinics also which run regularly. The mobile services or the outreach services, we have 58 clinic spots, but this caters to about 140 villages totally. And the services which we offer are again antenatal, postnatal, chronic disease management. Patients who are low risk are seen in the periphery itself and don't come to the hospital at all. And home visits, health education also happen via the mobile. So our future plans are still towards establishing a 24-hour hospital in Jawadhi. If we can actually do this, it will really help us a lot in cutting down travel time, costs, and so on and so forth, and definitely help patients reach us, because in the night time there is no access to healthcare for them. If we have a hospital in the hills, then we'll be able to widen our service area also. Geographically, what we are reaching now is limited by our travel time.